announcement a few minutes ago indicating that there were some issues with the registration link, so I want to remind everyone, if you are logging into the program, please log in with the registration links that were sent to you yesterday and this morning. If you have any questions, please contact my colleague, Cheryl Winkowski. Her email address is cwinkowski, WINKOWSKI, @foley.com. Again, please log in with the links that you received yesterday and this morning. We're happy to get started with today's program. The title is The ACO MSSP Regulations, an Opportunity or a Distraction. Joining us today are four great speakers: Fred Guilfus, Maureen Kwasinski, Chris Rossman, and Mark Waxman. Fred Guilfus is a partner from our Milwaukee office. He counsels healthcare systems, hospitals, medical clinics, rehabilitation agencies, nursing homes, and other healthcare providers on general operational concerns, regulatory and business matters. Maureen Kwasinski is a registered nurse and the senior counsel in our Milwaukee office. Her practice focuses on providing transactional, compliance, provider operations, and ethics counseling to providers, purchasers, payers, and other segments of the healthcare industry. Chris Rossman is a partner in Foley's Detroit office and co-chair of the Healthcare Industry Team Business and Transactions Work Group. He is a member of the Healthcare Industry Team and leads the firm's healthcare practice in Michigan. Mr. Rossman has represented clients in the full spectrum of healthcare law. He has handled several of the larger M&A healthcare transactions, major Medicare matters, payer disputes, and compliance issues. His practice is centered in the Midwest, but because of his national practice, he has represented clients in over 30 states. Mark Waxman is a partner in Foley's Boston office, where he is former chair of the Healthcare Industry Team and a member of the Government Enforcement, Compliance, and White-Collar Defense practice. His healthcare practice focuses on transactional, regulatory, and contractual issues for for-profit and not-for-profit providers and payers. Before I turn the presentation over to our presenters, I'd like to go over a few housekeeping items. The program will last approximately 1.5 hours. We encourage you to submit your questions throughout the program. Simply click Q&A on the menu bar and type your question. If time does not allow for us to answer your question, we will follow up with you to address it. Materials for today's program are available on our website at foley.com/FridayFocus, or you may simply click the print icon at the bottom right-hand side of your screen to print to a PDF. Foley will apply for 1.25 hours of CLE credit after the web conference. If you would like to receive CLE credit and you have not already provided your state bar number when you registered, please forward this information to mroth@foley.com. Today's program is being recorded and will be available on Foley's website. For audio assistance, please press *0. Now I'm very pleased to turn today's presentation over to Fred Guilfus.
Thank you very much, Melissa, and thank you all for joining us today. Our plan is not to go through the ACO regulations that were issued some time ago in any descriptive manner. Rather, after a brief summary of the regulatory scheme, we thought we would talk about 4 takeaways from the regulations. The first one is whether your organization ought to participate in matters to consider in making that decision. We're then going to discuss what is required for an application. Maureen Kwasinski will deal with that. The third issue, Chris Rossman will address issues warranting comment in the regulations. And finally, batting cleanup, Mark Waxman will talk about alternatives to the Medicare Shared Savings Program. Initially, we should note that the proposed regulations were issued March 31st and published the week after that in the Federal Register. Comments are due on the regulations June 6th. Simultaneously with the ACO regulations, CMS and the Office of Inspector General issued proposed regulations on legal waivers, and comments for those on those proposed regulations are due June 6th. Also, the FTC and DOJ issued a joint proposed policy seeking comments, and the comments on that proposed policy are due May 31st. And the IRS also issued a proposed notice seeking comments, and those comments are due on May 31st. So accountable care organizations have really been the talk of healthcare since health reform was passed in March of 2010. The regulations have been much anticipated, but since the issuance of the regulations, there has been some, the reaction has not been entirely positive. One senior state hospital association leader has called them counterproductive and asinine. Others have more sanguine views of the regulations, and we'll let you decide for yourself. But needless to say, I think there are some surprising things in the regulations. It is important to appreciate the regulatory scheme. It is not an HMO or controlled network model. And you have to have that mindset. You have to remove that mindset when you think of these regulations. There is no steerage allowed or contemplated, and there is no narrow network of providers. Really, the goal of CMS was to preserve the beneficiary's free choice of selecting a provider. That's a hallmark of the Medicare fee-for-service program. This is really in contrast to the Medicare Advantage program, which is much more of an HMO model. As was a surprise to many of us, there is retroactive assignment of beneficiaries. So when you treat a patient, you don't know at the time whether that patient's costs will be included or not in measuring whether you qualify for shared savings. Beneficiaries do not sign up. Rather, beneficiaries make their choice by electing to receive services from a primary care physician who participates. And the costs of providing care to that beneficiary are included if the beneficiary receives during the course of a year the plurality of their primary care services from a participating primary care physician. Primary care physicians are not exclusive to an ACO. I mean, they are exclusive to an ACO. They cannot participate in more than one. In contrast, hospitals, specialists, and other providers cannot be required to be exclusive. This, for instance, will mean that if you have a multi-specialty clinic with primary care doctors and specialists, the primary care doctors have to be exclusive, and the specialists cannot contractually be required to be exclusive. There is an application process to participate as an ACO, and you receive a 3-year agreement when your application is accepted. Maureen will talk about the details that need to be included in an application, and needless to say, it's not one you do the night before. The regulations also specify requirements for governance. The board needs to be 75% controlled by participating providers, and there also needs to be proportionate control by the participating providers. You also have to have a Medicare fee-for-service beneficiary on the board, and I think these governance requirements are likely to mean that very few entities won't have to establish either a new entity or a new board of directors a new governing board in order to function as an ACO and meet the eligibility requirements. The ACO requirements have significant requirements for leadership structure, data gathering, transparency, marketing, and compliance. There also are numerous quality standards and reporting on your performance against those quality standards, as well as on your costing, your cost performance. The payment continues the fee-for-service payment. So providers who participate are continued to be paid fee-for-service as they have in the past. But if they participate, there's the potential to earn a share of the savings, which is measured against a benchmark that is established. And the share that you receive, the percentage you receive, is based on the quality and the reductions in cost that are achieved. We'll talk more about those in a few minutes. Another surprise was that all participants, all ACOs, must assume some downside risk. There are two models. In the one-sided model, for the first 2 years of the 3-year agreement, it is only an upside or a bonus program where you share savings and you do not share losses. But in the 3rd year, you are required, an ACO is required to share in the losses that an ACO has measured against the benchmark. In the second choice, the alternative where you get a better share of the savings if you perform well, you also take a share of the downside risk from year 1. There's no transition, and you are at risk in year 1 as well. We also saw legal waivers for fraud and abuse laws, the Stark, the anti-kickback statute, and the CMP law, and proposed waivers, proposed safe harbors, and some other tweaks to the antitrust laws for those who participate in the Medicare Shared Savings Program. So with that brief overview, I thought we would talk about the considerations for whether it makes sense for your organization to participate as an ACO. What are the benefits and the costs? What are the financial benefits that you may receive? Are the financial benefits sufficient to change behavior? As we know, ACOs were billed as a way to transform how healthcare was delivered and change it from one that was focused on providing more services to providing better services and achieving better outcomes. And I think a fair question is it going to achieve that goal? Are there other benefits of participating besides the financial benefits? And importantly, what are the costs of participation? Under the formula that's set out in the ACO regulations, the financial benefit is the ability to achieve savings and receive a share of them. That is why, if you're financially driven, that is why you would decide to participate. That is the only financial benefit that is part of the ACO program as proposed in the regulations. As I mentioned, all participants still bill fee-for-service as they have previously. So this is a bonus or a potential loss, as I mentioned. And those are the benefits and some downsides to participating. So whether you receive this financial benefit is an important consideration as you decide whether to participate or whether you can achieve the financial benefit. This will depend under the formula on the number of expected beneficiaries that you think you will have in your ACO. And remember, we determine the beneficiaries that participated in your ACO at the end of each performance year. It will also depend on the Medicare Part A and Part B costs of providing care for those expected beneficiaries. Beneficiaries are assigned at the end of the performance year. So this is based on projections the benchmark is set based on projections of care provided to beneficiaries determined based on the primary care doctors that you sign up in your ACO. Another big factor will be, can you deliver cost of care significantly below the expenditure benchmark? That is, you will need to be able to reduce the cost of care provided to the beneficiary population below the benchmark, and the benchmark is inflated for cost generally of Medicare services nationally. But you need to wring some costs out, or you get no financial benefit. And you need to be able to meet quality measures that you report on. The quality measures tell you what your percentage share is of any savings. Now, again, the number of beneficiaries are assigned retroactively. The primary care physician participation is the key. And a big question is, will the beneficiaries who have historically used the same primary care physician continue to do so? Will they be loyal to that primary care physician? Will they stick with their doctors, or will they move around and receive care from different doctors? If you are loyal and follow your primary care physician and his recommendations, his or her recommendations for specialty care and hospital care, care may well be kept within the ACO participating providers. but there's no assurance that that's the case, because a Medicare beneficiary can receive care from any Medicare participating agency and provider. The average per capita cost of care will also be an important consideration. The benchmark is based on 3 years prior to the first performance year, based on the primary care physicians who you anticipate, who you sign up to participate in your ACO. A key question is your state a high or low Medicare cost on an average basis? Many states have wide variations between them in the cost of providing Medicare services. If you're in a low-cost state, it may be harder to wring out more costs and achieve savings. It's an important thing to consider. I know in Wisconsin, historically, we've been 30% or so below some of the high-cost states, like New York, for instance. And what will the makeup of your beneficiaries be? Will it match those that were used to establish your benchmark? Will they get sicker? Will they stay well? Will they consume less or more Medicare services? Those are questions, some of which you won't know the answer to, but it's a key consideration that ought to be factored into your decision whether to participate. It also depends on if you have any special Medicare costs in your benchmark, or if you didn't have them in your benchmark and you add them later, those can haunt you. Obviously, you want the benchmark to be a higher number so that you can achieve savings by driving care below the benchmark. And they base this on Part A and Part B services received by Medicare fee-for-service beneficiaries who utilized the primary care participating physician. And what are the attributes of your ACO provider participants? Do you have DISH hospitals? Do you have medical education providers? If you are a DISH, you'll receive, in the 3 years for which the benchmark's determined, you'll have a higher benchmark. Presumably, one way you could game it is if DISH hospitals in your benchmark, you could presumably refer away from DISH hospitals during the performance years and thereby lower the costs that would be allocated. Similarly, with medical education, that's in the benchmark, and it's also going to be factored in determining your actual expenditures. Medicare incentive payments for things like EHR can also be considered in setting the benchmark and in your determination if you've exceeded the benchmark or come in below it. So a real question is, can you deliver care significantly below the benchmark? And the question is, do you coordinate care well? If you have practiced coordinated care for the 3 years prior to it, you may already have taken some costs out and thereby lower your benchmark. So you really need to be able to coordinate care and drive down costs during the performance years as vis-a-vis the 3 prior years. What are the relative components of your benchmark? Hospital care is typically a very big portion of Medicare Part A and Part B services. And have you already been efficient with, you've lived in a DRG world for some time, have you already been efficient with the DRG reimbursement and driven down costs so that there isn't a whole lot more savings you can generate? It's an important consideration. Another big question is, will your participating providers cooperate to coordinate care? What controls do you have over them? An integrated delivery system with employed physicians may have significantly better control than if you just contract with a group of specialists that you need in your network, but all you'll have over them is contractual provisions that require them to share data with you and agree to comply with protocols. But their main driver may be their fee-for-service payment that likely will outweigh any incentives to be accountable in terms of shared savings for driving care below a benchmark. A key question is, how committed are the physicians to coordinating care and delivering efficient care? If they're not committed, and if they don't view it as their responsibility to provide only the necessary care, you'll have a problem. You really have to get a sense of who your participants are and how committed they are to coordinating care. Another question is, can you get timely reports on the care they provide? That will be critical to assessing and leaning on them if they're outliers in terms of utilization of care. Another question is, will the beneficiaries receive care from your participant providers? So you have participating providers and you have protocols in place to really manage the care that they provide, but will the beneficiaries stay with them? One question is, do they now? Do the Medicare beneficiaries keep their care within a select group of providers? And that really is the glue to help them keep the care within the ACO. Remember, there is no steerage in terms of higher copays or deductibles for picking care within from an ACO participant group. You have to rely on the glue that's where they seek their care. Beneficiaries have free choice, and again, that was an overriding core principle that underlies the ACO regulations. What about second opinions? So if you have someone in your community that offers them who doesn't participate in your ACO, they may get patients and beneficiaries that you hope are within your ACO to go to a different hospital, and where the care is not coordinated and the hospital is not following protocols. Is there a specialty hospital in your community that is a real draw for sicker patients? If you have a strong cardiac hospital and you don't have a contract with that cardiac hospital, but a high percentage of the Medicare beneficiaries in your community seek their cardiac care from that hospital, you may have problems in how you control the care and drive down costs. What about snowbirds? If your primary care doctor is in your ACO and he sits in the upper Northwest, but your beneficiary spends 6 months of the year in Florida or Arizona and receive their specialty care down there, their dialysis, some other things, how do you really control the care that's provided by the Florida or Arizona physicians? Can you get them to be in your ACO? Presumably you could, but I'm going to guess that most won't. And do you have any ability to control the nature of the care, the protocols that they follow when they're down in a different locale? Another key question is, will beneficiaries like to participate in an ACO? If you know your doctor is rewarded for providing less care, potentially rewarded for providing less care, will you want to be treated by that doctor? Now, there are some quality criteria that offset that, but it's still an issue. And another concern is you have to weigh in. If you're not successful in reducing the cost, you may owe money back in terms of shared losses. And under the formula that they've set up in the regulations, the percent of loss sharing is likely to be higher than the percent of savings. So you can take a bigger hit on the loss side than you can on the upside. Another question is, how will you perform on the quality measures? There are 65 measures in 5 domains, and these are things, many of which have been around for a while, and have you performed well historically on them? Are they things you can have and can track? And can you drive consistent quality scoring from all your ACO participants? There also may need to be a need for continued improvement. While not entirely clear, it appears that every year the quality measures are updated, and it will be necessary to show improvement over what you did in the prior years. So each year it may be a little more difficult to achieve a higher percentage share. Here is a chart I put together, and I hope you can read this. We've put together 2 examples, assuming one, you have 10,000 Medicare beneficiaries in one and 60,000 in the other. We've assumed that the average per capita cost which sets the benchmark, turns out to be $8,000. in each instance. So in the 10,000 beneficiaries, that would mean your total benchmark would have to be $80 million. And for 60,000 beneficiaries, your benchmark would be $480 million. To play in the game, you have to meet the minimum savings rate under the regs, which means in the 10,000 you would have to have a 3% or $2.4 million of savings before you can share anything. And in the 60,000 beneficiary situation, you would have to have $9.6 million. Now, there's also a floor. The minimum savings rate and the floor often get confused. The minimum savings rate is whether you can play the game at all, and the floor is CMS will keep the will keep the floor of any savings that are achieved. So if there are savings for the 10,000 beneficiaries, they're going to keep the first $1.6 million, which is 2% of the $80 million, and they'll keep in the 60,000 model $9.6 million. Now, the percent of savings you can receive in the one-sided model is 50%. In two-sided, the potential it goes up to 60%, and that's no matter how many beneficiaries you have. So and there's also a cap. The most you can receive under these assumptions in the one-sided model is 7.5% of the total benchmark, which is $6 million for 10,000 beneficiaries under the assumptions we have, and $36 million. That's the cap of what you can receive. In the two-sided model, it goes up to 10% of the benchmark, so you can receive more money before you're capped out, and CMS will retain the rest. Now, what we put together here is, assuming you meet the quality scores, you knock the quality scores out of the park, so you receive a 50% sharing rate. To receive the cap, or the $6 million for 10,000 beneficiaries, you'd need to show savings of $13.6 million off an $80 million benchmark, or a 17% to get to that. That's at the max sharing rate. Because there's no floor in the two-sided model, it's only 16.6%, $13.33 million of savings in the one-sided model, and $79 million of savings in the two-sided model. 79.68 million with 60,000 beneficiaries in the two-sided model. And we've also put together here, let's assume that you only achieve half of the quality scores, so that you receive 1/2 of the total percentage savings that you can receive. And in that instance, you would have to wring out $25.6 million, or 32% of the $80 million, to receive $6 million, and or $153 million of savings off of a $480 million benchmark, also 32%. And in the two-sided model, it's less than that. It's 23% in each model. So I think that I found this helpful because it sort of puts a little bit of parameters around how much money you can expect to share, and what you have to do to achieve that sharing. Now, we haven't even focused about the costs. Those are just the benefits of what you can do if you function appropriately. The costs, you may need a new board. You have to have 75% control by ACO participants, and you have to have proportionate control by ACO participants. You need to have a beneficiary on your board. So I think you may have to create a new organization, or at least a new governing board, in order to participate as currently structured. And it's very possible, they're talking about control, that if you you're a hospital, you set up an ACO, you invite all the participants to be on your board, they're going to act independently, or they may act independently. And one question is, can you get your board to participate and follow what you want? They should have aligned interests, but anytime you get a group together, you need to worry a little bit about that. And a big question is, will they have sufficient funds to implement the required steps? The infrastructure and operating costs are not insignificant. You have to think about sharing IT, linking health information, having an electronic health record. You have to be structured so that you can measure and control the costs and claims. You are required to have a full-time medical director who is on site. That's spelled out in the regulations. You need to have an executive director. It doesn't need to be full-time, but there is an executive director who's in charge. It's likely to be full-time if the ACO has any size. You've got to be able to deliver care coordination, quality improvement, utilization management. You have to report and collect data from all your participants or get them to agree to do it. Data analytics will be critical. The completion of the application is not insignificant, and it will include a variety of things, including network development and getting your contracts in place. You'll need to develop a compliance plan and retain a compliance officer who, in CMS's current mode, cannot be the legal officer. It cannot be the lawyer for the ACO. You'll have to prepare your antitrust analysis, and we'll talk about that a little bit more later. That can be not an easy thing to do, I would think. You'll develop your contracts and your network and get them in place as part of your application. You'll have ongoing reporting. You'll have to have effective and enforced care management if you have any hope of achieving some savings. And you take downside risk. But also the downside risk may require state insurance regulation. That is mentioned in the ACO regs, and I think most people think that it likely does involve the business of insurance. We haven't heard from state insurance regulators yet as to their perspective, but if that's the case, there'll be a significant added expense. You also need to worry that CMS can change requirements. There are a few requirements that CMS is precluded from changing, but the ACO regs do permit them to change requirements. And CMS data may not be available. Beneficiaries may opt out of agreeing to share data. So if that happens, you have to contemplate how you will obtain the necessary data if CMS doesn't provide it. CMS estimates the cost of participation to be about $1.7 million. More recently, I saw a study that the American Hospital Association and McManus Consulting put together. Now, this was put together prior to the ACO regs being issued. It was based on what people thought the ACO regs would be, and they looked at the costs of putting together an ACO, an effective ACO. They looked at network development and management, care coordination, quality improvement, and utilization management, cost of clinical information systems, and data analytics. And they came up with two different estimates. For a one-hospital ACO with 80 primary care physicians and 150 specialists, they estimated it would cost $5.3 million to set it up and $6.3 million ongoing. For a larger system, 5 hospitals with 250 primary care physicians and 550 specialists, the numbers were $12 million to set up and $14.9 million for ongoing. If these estimates are close to accurate, and my guess is many will have gone down the road to even before they decide to participate, of putting these things in many of these things in place, so the estimates may be a bit high. But if these are close to accurate, and you saw what the benefits are, I think there's a real question whether it makes sense to participate. Other questions is, how do you pay the cost? You know, the shared savings are only known and paid at year end, but you have significant upfront costs. Will there be a return on equity on your investment? A clear unknown. And where will the investment capital come from? Who will make an investment if you don't have control and the return isn't known until the end of the year? You also need to develop a plan to share savings as part of the application. So if you receive the maximum shared savings share that you can, you still want to share that with the participants so that you can motivate their proper behavior. And you need to develop a plan on how you're going to do that. Presumably you'll want to recoup some of your infrastructure costs, so that'll be an important aspect of it. And will the amount shared be meaningful against the fee-for-service payments that providers have? There also is what happens after 3 years. There may be resetting of costs and expenditures to determine that benchmark. So if you have really been successful and really driven down costs in the initial 3 years and received the maximum shared savings, they may reset your costs and your benchmarks for the subsequent 3 years, reflecting your success, which means that it'll be very difficult to continue to show improvement, and that may scare people away and mean it's really just a 3-year transaction. And the same thing with quality. Can you continue to show quality improvement? And it may be harder to realize savings after the initial 3 years. This is something the antitrust shares will also be important. One advantage that is afforded by the antitrust policy, the proposed policy, is if you participate in the Medicare Shared Savings Program and you meet the antitrust safe harbor, then you can jointly contract for commercial markets if you have similar governments and operations. So that could be a benefit from participating. Again, I think a critical issue is, can you get your participants to be committed? For independent hospitals and specialists that are just a vendor and don't operate the ACO, there may be less to lose by participating. They may think that they'll get more referrals on their fee-for-service business if they participate, and we may see independent hospitals and specialists signing up or being willing to sign up pretty readily. And again, CMS can change the rules. That was a quick review of a number of the considerations that you ought to be thinking about as you go through it. Now we're going to talk about, if you decide to participate, what do you need to put in an application to participate. And I'm going to turn it over to Maureen Kwasinski.
Thanks, Fred, and good afternoon, everyone. Happy Friday. As Fred said, this next portion of the presentation, we're going to talk about the requirements, the documentation that needs to be included in an ACO application. These requirements are somewhat scattered throughout the proposed rule. So what we've done for today is organize the requirements into 5 different sections. So this is done by us and not something set forth by CMS. The 5 areas that we're going to talk about are the governance and leadership requirements, the compliance and quality issues, the shared savings and losses and repayment obligations, the antitrust analysis, and then the documentation that needs to be produced regarding the ACO participants' rights and obligations. In your invitation to attend the presentation today, there is a link to a handout that we provided. It's a checklist of these requirements that will track what we're going over in these slides. And we put that checklist together for your use as a tool should you decide to apply. It provides you some sections in which you can identify who the responsible party will be for that aspect of the application, a description of the documents, and a status to track the development of your submissions. And so you can use that checklist to follow along this afternoon or just work off the slides. You'll note on the slides and also on the checklist there are parenthetical citations. The CFR citations cite directly to the regulation. The other numbers that you see are page numbers to the proposed rule. So that aspect of the requirement will be described on those pages of the proposed rule. So there are 28 separate requirements that we're going to talk about today. And I apologize in advance for the dryness of this section. What I think you can appreciate after we review all 28 sections is the time and effort that will be involved in developing a complete submission. As Fred mentioned earlier, this is not something that you're going to be able to put together overnight. Your ACO and the plans for the ACO and your clinical plan needs to be set forth in pretty significant detail to have a complete submission. Sorry about that, I skipped one of my slides. So let's jump into the governance and leadership requirement submissions that need to be included with the application. The ACO has to provide evidence that the ACO is a recognized legal entity in the state in which it is established and in any state in which it is authorized to conduct business. In addition, the application must include evidence that the governing body is a separate legal entity. The application also needs to include a description of the ACO's organizational and management structure, and that needs to include an organizational chart, a list of committees and their structures, including names of the committee members, and job descriptions for senior and administrative clinical leaders. So this is a good example of how well developed CMS expects the ACO to be at the time of the application submission. As Fred mentioned earlier, the ACO must have a board-certified physician to act as the ACO's medical director. That medical director must be licensed in the state in which the ACO resides, and the application must include something such as a copy of the medical director agreement to demonstrate that the ACO has engaged an appropriate medical director. The application must also include evidence that the ACO's leadership structure has identified an individual who will serve as the ACO's principal CMS liaison. And as Fred talked about earlier, CMS is very concerned about the composition of the ACO governing board. So in the application, the ACO must include evidence that the governing body includes individuals who represent the ACO participants, and those representatives must hold at least 75% control of the governing body. That needs to be demonstrated in the application. There also needs to be evidence in the application of patient involvement in the ACO governance. Again, as Fred mentioned earlier, it is important to CMS that the ACO is functioning as a part of the community and serving the population, so the application must include a description of how the ACO plans to partner with community stakeholders. And if the ACO has a representative from a community stakeholder organization serving on the governing body, they would be deemed to have satisfied that criteria. Finally, upon request from CMS, the ACO has to be prepared to produce documents describing and demonstrating the ACO's formation and operation, including charters, bylaws, articles of incorporation, and other agreements that were used to develop the ACO, partnerships, joint ventures, management, or asset purchase agreements. Those also need to be available upon request from CMS. Moving on to the compliance and quality aspects that need to be demonstrated in the application. If the ACO intends to request beneficiary claims data, in the application, the ACO has to provide a detailed description of what it plans to do with that data. And it needs to have to show that it is going to use that data to evaluate its performance and the performance of ACO participants and providers and suppliers. It has to use that data to conduct quality assessment and performance improvement activities, and it should be also using that data to conduct population-based activities to improve the health of its assigned beneficiary population. In the application, the ACO needs to be able to document its plans to promote evidence-based medicine, including a description of the evidence-based clinical guidelines that the ACO intends to establish and implement and update. So again, another example of how well-developed and well-structured the ACO needs to be, even from a clinical perspective, prior to the submission of the application. CMS is very concerned about beneficiary engagement, and the application must include documentation of the ACO's plans of how it's going to promote beneficiary engagement, including a description of the processes that it plans to use to establish the processes it's going to establish, implement, and update to promote that engagement within the ACO. Still further, CMS is expecting documentation of the ACO's plans and how it's going to internally report and collect information about quality and cost metrics, including a description of the process it's going to use and how that process is going to meet the needs of the population seeking services within the system. The ACO has to have a well-defined plan for how it's going to coordinate care among ACO participants. The ACO must include in the application a copy of its compliance plan or documentation that describes the plan that will be put in place at the time that CMS approves the ACO agreement and it becomes effective. The ACO has to have defined and be able to describe in the application the scope and the scale of the quality assurance and clinical integration program, including documents that will describe all relevant clinical integration program systems and processes, such as the internal performance standards and the processes that will be used to monitor and evaluate ACO participants' performance. Additional requirements include, again, CMS is very concerned about the experience of beneficiaries within the ACO and the level of satisfaction they have with the care that's provided. So within the application, the ACO needs to describe how it will survey beneficiaries to determine their experience and satisfaction with the care that is provided through the ACO, and how the ACO will then use those results to improve the services that they deliver to ACO beneficiaries. The application must also include a description of the ACO's process for evaluating the health needs of the ACO population, including considerations of diversity among ACO beneficiaries, and a plan then to address those identified health needs. CMS is also very concerned with not only population health, but how the ACO plans to deliver services for the unique needs of beneficiaries as individuals. So the application also has to describe the ACO's individualized care program, along with sample care plans and an explanation of how that program will be used to promote improved health outcomes. And in particular, CMS is concerned about those high-risk patients and patients with multiple chronic comorbidities or multiple chronic illnesses. Also, CMS would like the ACO to describe any additional populations that would benefit from individualized care plans. The ACO must also develop and include with the application written standards for beneficiary access and communication within the ACO, and that must also describe the ACO's process for providing beneficiaries with access to their medical records. Moving on then to the requirements that are associated with the shared savings and losses and repayment obligations. In the application, the ACO must include a description of how the ACO's proposed plan will distribute the savings. As Fred mentioned earlier, the shared savings need to be used to incentivize ACO participants, and the application needs to describe how that's going to happen. So there needs to be with the application a description of how the ACO plans to employ the distribution of shared savings among ACO participants, how the ACO's plan will help achieve the specific goals of the shared savings program, and achieve the general aims of better health for populations and a lower growth of expenditures within the ACO. Importantly as well, as Fred mentioned, ACO participants need to share some of the risk of the downside. And so Medicare is expecting that the ACO be able to demonstrate its ability and a mechanism to ensure repayment of any losses that occur. And so examples of that would include a reinsurance program, placing the funds in escrow, obtaining a surety bond, obtaining a letter of credit that the Medicare program can draw upon, or some other appropriate reliable repayment mechanism should there end up being a significant repayment requirement. And this is required at the initial application for both the one and the two-sided models, even though there isn't a potential for loss in those first years of the one-sided model. In addition, the ACO needs to include with its application copies of the signed agreements that it has with ACO participants, establishing their liability, including any percentage of shared losses that the ACO participant would be responsible for. Importantly, and one of the more labor-intensive aspects of the application is the antitrust analysis that Fred mentioned earlier. This is a letter from either the FTC or the DOJ is required for any ACO with a PSA share above 50% for any common service that two or more independent ACO participants provide to patients within the same ACO. So it is necessary for the ACO to do some preliminary analysis to determine whether or not it needs this letter from FTC or DOJ, and that will require some significant data collection from ACO participants. You know, you would generally need to get a complete list of the services provided by each participant, identify common services and the volume of those services within each ACO participant's primary service area, and then make that final determination on the market share within the PSA. So if no PSA has a market share of greater than 30%, the ACO would be within the safety zone and you would not need that letter. But if the PSA share is above 50%, you would need to make a submission to the FTC or the DOJ to obtain that review letter. Lastly, with regards to ACO participants' rights and obligations, the application must include ACO documents, copies of ACO documents, participation agreements, employment contracts, operating policies, documents that describe the participants and providers' rights and obligations, the shared savings, and evidence-based clinical guidelines that will be used. The application must also include a certification by an ACO executive who has the authority to bind the ACO that all the ACO participants are willing to become accountable for and will report to CMS on the quality, cost, and overall care of ACO beneficiaries. As I mentioned earlier, copies of signed agreements with ACO participants establishing their liability, and finally, upon request from CMS, descriptions of the remedial processes that will apply if an ACO participant or a provider supplier fails to comply with the ACO's plans, including any corrective action plan, and the circumstances under which a participant could be expelled from the ACO. So as we mentioned earlier, the application submission is quite detailed, and after, if you meet all 28 requirements, it's a significant volume of data. As far as submission deadlines go, the regulations generally say that they have to be submitted by a deadline established by CMS. And CMS will determine whether to approve or deny an application from an eligible organization prior to the end of each calendar year in which the application is submitted. Significantly, if you do need the FTC DOJ antitrust review, you have to give them at least 90 days to review your application prior to the date of submission to CMS. So, and importantly, it's not that you give information to the FTC DOJ while you're working on the other aspects of your application. You give the application to the FTC DOJ at least 90 days prior to the submission to CMS and then obtain the review letter. So realistically, if CMS says you can submit a application on November 1st, which would really only give them 60 days before the end of the calendar year, you would still need to get the whole application to FTC DOJ in the beginning of August. Next, we're going to move on to Chris Rossman in our Detroit office, who's going to talk about the aspects of the proposed rules and policies that may warrant comment. Chris?
Thank you, Maureen. This is a fairly detailed set of overheads that I prepared that actually our whole group's worked on. We've got about 22 slides here, and I'm going to try to summarize this in about 10 minutes so that we have time for Mark Waxman's section, which you'll find at least, if not more, interesting than my section. The process for commenting is listed. It's already been mentioned that June 6th would be the deadline for the CMS portion of the regulations, and so there's not a lot of time left, and there's a slide here on slide 40 about how to submit it, and significantly, faxes are not accepted. These overheads that we prepared are primarily based upon specific comment requests that CMS included in its proposed rules. And the proposed rules include probably as many requests for comments as we've seen in recent memory by CMS when they come out with a proposed rule, and it really indicates that they view this as a work in progress, as do we in the industry. There are pretty much every aspect of the rules are specifically identified as warranting comment. This presentation is just going to highlight some of the more interesting aspects. There's been quite a bit of discussion about the types of providers and suppliers that should or should not be included as potential ACO participants, and CMS is looking for additional information on that. They aren't quite sure who should be in or not allowed to be in, and there's some more specific questions that are included in the regulations themselves, and if you're involved in putting together an ACO that doesn't quite fit within the existing proposed rules, it could be really beneficial to submit a comment on this. CMS is also encouraging direct communications with them in addition to written comments because they're really interested in getting the industry's views. So if you have issues that you believe warrant a telephone conversation or even a meeting in Washington or Baltimore, wherever appropriate, those are something that the CMS contact people listed in the proposed rules have expressed specifically that they're very interested in arranging for that. They really want to reach out to the industry to develop something that has a chance of being very successful. So they're concerned about how to monitor particular partnerships. There's also a lot of concern throughout the whole regs about whether or not there's going to be sufficient information available to CMS to allow for them to identify situations where there is a compliance problem or where where the money is not being distributed appropriately. CMS asked for comments on whether or not there should be a requirement for a distinct legal entity, which isn't in the regulations now per se, but it would be very difficult for an existing legal entity to meet all of the governance requirements that are set forth in the proposed rules. It would certainly, I think, require some restructuring of an existing legal entity, and it really might not make sense. For example, if a hospital is the main entity putting together an ACO, it's probably not going to want its governance to be changed in a manner that would meet the ACO requirements. So CMS is looking for comments on simply whether they should require a separate legal entity altogether. And then there's also questions about ACO participants, the extent to which they need to identify representatives that will participate in the governance process, and they've asked for additional guidance on that as well. CMS has indicated that it's really intending to encourage not-for-profit community-based organizations to participate in the shared savings program, and I think that kind of indicates a perspective that they have, but it's important for the industry to respond to that and whether or not that's really appropriate, because certainly on the hospital side of things there's a lot of nonprofits, but in many other ACO participants there are few or none. It's very rare to see physician groups as nonprofits, for example. So we're going to clip through that since we talked about that. The 75% control requirement of the governing board is an issue that by ACO participants is an issue they'd like additional feedback in, and they're not quite sure. They've been told by industry that there are entrepreneurial management companies and health plans that have expressed interest in forming or participating in ACOs, but in many circumstances the 75% control issue is problematic for them. And certainly when there's a large infrastructure and additional capital involvement, and it's not contributed proportionally by the governing body, that creates significant control issues. So that also is appropriate for consideration of comments. It kind of gets to the position that Fred was saying earlier on, that there are certain aspects of this that are problematic, or as Fred quoted one person, perhaps a little less diplomatic than that statement. So there are most likely going to be some significant changes, and there's going to be a large volume of comments, and they certainly encourage you to make yours. Should there be more than a 3-year period? CMS is, for the initial agreement that is, CMS is looking for comments on that, and they've actually considering a structure that would involve at least a 3.5-year comment period we'll get to in a moment. I'm trying to hit the highlights because you can certainly read these slides at your leisure. The taxpayer identification number is very important to CMS. They actually don't require that the ACO itself be enrolled in the Medicare program, but they do require that all ACO participants be enrolled. And also they want to get the taxpayer identification numbers of all the ACO participants so that they can monitor program integrity concerns. And they're asking for comments on whether or not the shared savings payment should be made directly to the ACO as identified by its taxpayer identification number as proposed, or whether payments could be made to ACO participants. Also, they're concerned that the ACO itself might not be a Medicare enrolled entity, which raises concerns as to whether CMS has sufficient control over it to identify and deal with overpayment situations and repayment situations. So they're looking for guidance on that as well. They're also looking for guidance on the issue of the 5,000 beneficiary minimum threshold for each year, and they understand that that may be problematic, and I think comments regarding the retroactivity issue that Fred discussed earlier would certainly be very appropriate. During the first year, CMS will issue a warning if the population falls below 5,000. After the first year, things get pretty serious where the ACO would be on a corrective action plan. It not at that point be eligible for savings, and CMS could simply terminate the ACO from the program. Many commenters have already mentioned that 5,000 would be small beneficiary population anyway, and that that type of population may be kind of near the edge of where it's even relevant for the ACO to continue to participate in the SSP. CMS proposes a number of criteria for patient-centeredness, and they're asking for comments on whether these criteria either contain redundancies or additional criteria should be proposed. And they're also asking for comments, as I mentioned before, on beneficiary involvement in governance. They're concerned about conflicts of interest, and ACO should be concerned about that as well. So if that's an issue that you run into or think is worthy of comment, should look into that. CMS is aware that the clock is ticking, and they have recognized in their publication that the January 1, 2012 start date is rapidly approaching. One proposal that they've suggested is to have an additional start date available of July 1, 2012, and that providers or ACOs taking advantage of that could have a 3.5-year agreement period. They're also asking for additional comments on other alternatives that might work to address that issue. There's been a lot of discussion about claims data already, and I'll only mention that it's essential that the providers and the ACO participants have as much claims data as possible available to them so that they can understand whether or not they're doing a good job or not so good job on quality and patient satisfaction. CMS's concern in the regulations seems to be more related to structuring the claims data flow so that they make sure that they accurately calculate any shared savings payments so that if there's an overcalculation, the chances of that are minimal, and they don't have to get involved in some kind of a recoupment issue. So there's competing objectives here, but from the ACO perspective and the provider's perspective, without accurate and timely data, they're not going to be able to achieve their goals. And then the question of whether or not there's a 3 or 6 month run out for the data runs into this calculation. So they're looking for information on that as well, and they're talking not only to ACOs but also some of the data organizations. The rules contain extensive and really important provisions for evaluating shared savings, data sharing, sharing of aggregate data, and sharing beneficiary identifiable claims data. CMS understands these rules are far from optimal, and it's really interested in comments from the industry to improve access and use data within legal boundaries. And we know from some direct discussions with the CMS officials that they don't believe they have currently sufficient legal authority to access all the data from an ACO participant. Plus, one of the weaknesses is that ACOs from ACO beneficiaries can access both in-network and out-network and services, and it's not possible for the ACO to capture all of the services the beneficiary is getting. Therefore, it becomes very difficult to manage the patient care of the beneficiary. And CMS is very interested in comments on how they could, within existing law or propose legal changes, to allow them to have a better grasp on all of the claims data for a particular individual ACO beneficiary. So this last overhead identifies some of the legal issues that CMS has been looking at, and anyone that has information there that in terms of how they would suggest improving that issue could submit a comment, or alternatively a comment that without better access to data, perhaps the ability to participate becomes much more problematic. At this point, I'd like to turn the program over to Mark for some comments on alternatives to participation, which kind of feeds into some of the comments I was just making. Mark?
Yeah, thanks, Chris. I mean, my role here is to give you a teaser for our next program, which is going to explain what you do if you don't do this. And I think we start with what is hot off the press from CMS. I don't know if this was in the offing at some point anyway, or what has happened here is the ACO proposed regulations came out, and they were so onerous and so difficult and so challenging that it really became obvious that to get any degree of meaningful participation, it really became appropriate to begin to modify the original construct. So what we have here are two things, published this week by CMS indicating new flexibility designed to address particular issues, but also designed to look at different sorts of structures. The first is the Advanced Payment Initiative for the ACOs that want to continue to pursue the Medicare Shared Savings Program. The idea here is that it would be helpful to have funds coming out of participation that would let you fund the infrastructure necessary to make care coordination as an ACO work without waiting for shared savings, which are speculative in nature or may not come until the second or third year down the line. So the question is, what does that actually look like? We only have really an outline of bullets at the moment, which says, an advance on shared savings will be based on expected earnings, so you'll put together a pro forma. You'd be able to get a monthly payment. It's based on something called an aligned Medicare beneficiary. It would require an indication of how the monies would be spent and then would be recouped from savings going forward. Sounds attractive. Comments shall be submitted by June 17, 2011 as to how this might work. Those who are looking to projections of shared savings may find there is some money to help for infrastructure here, but whether that's enough or not to entice more people to participate, we just don't know. Second approach is something called the Pioneer, I guess I call it the Early Settler ACO application and approach, which is a different ACO model than the MSSP model. It's designed for those who are experienced in care coordination. The idea here is to create an alternative ACO organization that would move from a shared savings payment fee-for-service-based model to a population-based payment model, i.e., although it's not stated, capitation, right, per beneficiary per month. It's on a track to be consistent with but separate from the ACO MSSP program we've been talking about. Interestingly enough, it's directly to be tied to coordination with private payers. I'll come back to that. It's going to have a higher share of savings than is currently proposed for the MSSP program. It's going to have a lower benchmark to savings. It's going to require strong patient protections to be a part of it. If you go online under the Innovation Center, you'll see already there the full Pioneer model request for application, a letter of intent, which will be due in June on a non-binding basis, that will give a further indication of sort of what it is that's actually required. Before I go to some of these other models, let me just say that the Pioneer ACO model is not the same. Although it's called ACO and it's the Pioneer is associated with it, and some of the structure is going to be the same, it is clear that there are going to be some rather significant differences in terms of how this is going to work. Several of those key differences will be the participation of other providers. For example, the Pioneer model will require ACOs to have at least 50% of total revenues derived from outcomes-based contracts by the end of what they call the second performance period. So this is going to require an integrated approach with your commercial payers to hit this 50% trigger as part of the plan. What happens if you don't, et cetera, a lot of open questions, and an entire other regulatory scheme will probably result, or these will be individual contracts, we'll see. Performance periods, the 3-year agreement will be contrasted with something that will actually be longer than 3 years with some additional extension options that may take it out an additional 2 years, so we're looking at something different there. The core payment arrangement will be moving towards the population-based payment during the third period. Read that capitation, and where this model is going to go on the payment arrangements may head in a different direction. The minimum number of beneficiaries you heard previously discussed at 5,000. Now, except for rural areas, we're now talking about 15,000 instead of 5,000. The alignment will be prospective or retrospective, obviously a significant difference. The alignment algorithm, as it's called, you may recall, was based on allowed charges for the PCPs. Now it's going to allow non-MD PCPs as part of the alignment algorithm. which may lead to a slightly different result. But in other areas, it'll be the same, patient-centeredness, performance metrics, and the like. So something there that will be different, that may entice others to participate in an ACO program as opposed to not. Slide 64, I just wanted to point out that, when you look at 64 and on into 65, what are the alternatives? Well, there are alternatives out there, some of which are PPACA-based. On the slide, you'll see the health homes, pediatric ACOs. I was just mentioning some innovation center projects. There are others, for example, certain bundled arrangements we'll see going forward through the innovation center. There are also other demonstration projects, some of which, payment bundling around hospitalizations, other types of inpatient hospitalization demonstration projects, school-based health centers, and, a whole bunch of other stuff that we will see continue to evolve. The alternative, of course, is to say, do I really need this for where I want to go? So let's not forget that there are managed care exceptions to Stark and the kickback statutes already built in. We have a toolbox of co-management, gain sharing, practice acquisition arrangements which are leading towards integrative effort between physicians and hospitals. And as we look at those, we also still need to be mindful of antitrust enforcement policy, but there's a fair amount of literature and guidance that is already out there with respect to clinical integration, principally found in the FTC advisory opinions, of which 2 are listed here with respect to, what does it take to clinically integrate. This is not a new topic. It's something that has been discussed through the enforcement policy itself in statements 8 and 9, as well as in the advisory opinions that are out there about what clinical integration actually will require, at least for the antitrust enforcement agencies to say, we think you've got there. You can get rule of reason treatment for clinically integrated multi-provider networks, and I would call everyone's attention to the enforcement policy on multi-provider networks in its discussion on those points. And I think we also go back to, if you're not going to get there, what are we going to do with the existing models that may not be at the level of clinical integration required for rule of reason treatment under the enforcement statements? And we go back and we look at what it takes to operate a messenger model without, running afoul of the antitrust laws, not to mention the Stark and the anti-kickback laws. But what does it actually take? Again, set forth in the statements. And there are a number of statements, examples of multi-provider network operations involving PHOs that either are, clinically integrated or are per-case basis models that are out there, or go back to even messenger model structures. So there is some guidance that is out there if you want to pursue the other models. Let me say, the guidance is not going to solve everybody's problem. The guidance is, I would call, guidelines, where additional guidance would be helpful. And for that, I would urge everyone on the phone to ask CMS to go back with the OIG and look carefully at and finally come to closure with respect to the risk-sharing exception that had been promulgated in draft form a couple years ago, and we'd sure like to have out there and see the light of day on a final, so at least we would have better, clearer, more productive guidance around risk-sharing arrangements from bundling on up to withhold payments, bonuses, and the like, in terms of what the sharing can be between the hospital and the other providers, principally the physicians. As we look at a lot of health homes, a lot of people are looking at health homes, as alternatives. The health home model is to look at chronic conditions around health home services, which have designated providers. You might think of it as, I wouldn't call it a poor man's, I would call it a more limited ACO model that you might look at as an alternative to going the full bore on an ACO. Let's say, can we do a health home, meet those requirements, get ourselves into the program that way, align with the commercial payers around that segment as a carve-out, as a way to begin the integration process at a higher level without requiring the entire range of requirements, including the mandatory antitrust review, exclusivity requirements, and a host of other practices that may be just too much to take on with respect to the ACO directly itself. If you want to run down the managed care and other available Stark and anti-kickback exceptions we put on this slide, here are things to go look at. If you fall in these buckets, there's actually a fair amount of flexibility. The guardrails, provided you meet the base requirements, are fairly flexible in terms of what can happen within the Stark and anti-kickback rules in terms of allocations of dollars within those buckets. So I would encourage everyone to go look at these particular exceptions, and I think we'll probably be covering those in more detail in a next session. With that, we're close to the end, so let me close it out for questions and answers.
Hi, thanks everyone. We do have a few questions. Start with the first one is, what does proportionate representation of the participants on the board mean? And if the ACO has 25 PCPs and 75 specialists, does it mean that the PCPs cannot be more than 25% of the board?
I can try that one, although I think the answer is the regs don't specify what proportionate representation means. At one point they say that the board needs to be have 75% representation of the participants, and then it also says it needs to be proportionate. They don't specify that there's a primary care versus specialist kind of allocation, and they're just generally not clear about what it means. But presumably you have to give those who participate, independent entities that participate, as well as bigger IDSs, representation that reflects in some fashion the size of their participation. Sorry we can't be more helpful on that one. Does anybody else have, any other speakers have a view of that?
Okay, let's go on to the second question. Do the proposed rules really require that an ACO get an antitrust agency letter whenever even one primary service area is greater than 30%? Do you think this is administratively feasible without slowing the process down too much?
I'm happy to take that as well. It's actually 50% is the mandatory. The PSA share of greater than 50% is where you have mandatory review and submission. It no doubt will slow the process down. They've indicated that they will provide a 90-day expedited review of it, and they indicate in the proposed policy a variety of factors they will consider in reviewing whether they'll grant an exception for the 50% plus participation. But undoubtedly it will slow things down. It's cumbersome to collect all the data, to submit it, and then there's no assurance once you've done that you'll receive approval. But my guess is it will take most of the 90 days expedited review to try and get the review completed.
Okay, thanks. We have another question, and this looks like multiple parts. Why is there any concern that state departments of insurance would consider this the business of insurance? I thought NAIC and most states have long opined that FFS with shared savings approaches do not meet the definition of insurance because they don't involve actuarial distribution or spreading of risk, as is found in capitation or percentage of premium approaches. If this were the business of insurance, then how would you distinguish per diem, DRGs, and case rates?
Well, the ACO regs mentioned that it may be viewed as the business of insurance, and I think it's clearly the loss feature of it, not the bonus feature that drives that. If you view the sharing of the losses as here's your benchmark, and if you don't bring care within that benchmark for this population, that you will pay a penalty, at least within a corridor. It's capped, and you pay a percentage of the losses. But it starts to sound, and you can make it sound not too distant from capitation, that you have to deliver care within a set total cost of care for a population. And if you don't, there's a penalty, and that could be viewed as the business of insurance. I don't think we've heard from insurance regulators yet. CMS raised the question about insurance regulation in the regs, and I think there is an issue there.
Okay, well, this wraps up our time. We invite you to contact today's speakers if you have any additional questions or would like more information on their particular topics. If we were unable to answer your question during today's program, we will follow up with you to address it. Thank you and have a great day. Bye-bye.